Hello, everyone. My name is Dan Wilson. I'm a registered respiratory therapist with FSHD. I am happy to present this webinar to you about how FSHD can affect the respiratory system. I want to thank the FSHD Society for allowing me to share this information with you, and thanks to Jun Kinoshita for her direction during the stages of developing this presentation. Let me begin by giving you a little background about myself. I was diagnosed with FSHD right out of high school in 1979. Through elementary school, I played sports and I was active outdoors. During my teen years, my parents noticed that I had the classic rounded shoulder, slouching appearance when I was standing or walking. "Stand up straight and stop slouching," my dad would tell me. I noticed problems with push-ups and chin-ups in gym class, but thought it was normal at the time. I didn't have the athletic appearing body type. I was just a scrawny teenager. After graduating high school, I never felt the effects of FSHD. I remained active and worked in machine shops. One day at work, my supervisor noticed I had trouble raising my arms above my head while I fastened a screw into a machine part. He was concerned that if something would fall toward me, I wouldn't be able to support the weight and become injured. I was a liability, and he wanted me to get a physical exam. The physical exam revealed something was not right, so I was sent to a neurologist for further evaluation. I completed the battery of tests, including blood work and an EMG. My CPK was elevated, and the EMG was abnormal. There were no genetic tests back then, so next came a muscle biopsy that confirmed my diagnosis. I did ultimately complete genetic testing, and my official diagnosis is FSHD1. After diagnosis, my neurologist advised me to consider a career path where I would use my brain and not my muscles. He told us that over time, FSHD would progress and my muscles will atrophy and get weaker. My ability to have a long-term career in an occupation that required physical strength would be risky. My parents and I were introduced to the Muscular Dystrophy Association and referred to vocational rehab. It was here that I was introduced to the healthcare field and was told the profession of respiratory therapy was on the rise, in need of people to be trained, and had a good long-term job outlook. No heavy lifting required. The next semester begins soon, we were told, and we, the MDA, will help fund your education if you decide to enroll. I said, sign me up. I completed the respiratory therapy program at Ivy Tech in Indianapolis, Indiana, and earned my associate's degree. I have been a licensed respiratory therapist since 1984 and have held many roles in the profession. I have had many mentors and coaches along the way, and the field of respiratory therapy has been a blessing and very rewarding to me over the years. One of the roles I have been privileged to be responsible for was faculty educator in the respiratory care program at Ivy Tech in Indianapolis, where it all began for me in 1979. I am an active member of the American Association for Respiratory Care, and I hold credentials as a registered respiratory therapist and certified pulmonary function technologist through the National Board for Respiratory Care. I hold certification as asthma educator through the National Asthma Educator Certification Board. My most recent role as an RT has been asthma and COPD patient educator. Presently, I am semi-retired, and for many years, my goal has been to give back to the MDA and provide education about how the lungs can be affected by neuromuscular disease, asthma, and COPD from the perspective of a respiratory therapist. So let's get started. I have no conflicts of interest to disclose. I have volunteered to provide this presentation for the FSH Society. Please understand that I am not a physician, and this presentation is only a basic overview. The information you receive during this presentation is to be discussed with your physician about specific direction in your plan of care. Here is the information I will present to you. First, I will provide a basic explanation about how the lungs work. Next, I will describe how FSHD can affect the lungs and how the doctor monitors our lung function. In some cases, treatment may be necessary if breathing and coughing become difficult, and I will summarize treatment options. Lastly, I will cover how we can prevent breathing problems and keep breathing healthy. Let's begin by going through the basics about how our lungs work. The respiratory system begins with the nose and mouth. This is called the upper respiratory tract. The air we breathe contains oxygen. Oxygen is a source of energy for normal body function. As the air enters the body through the upper respiratory tract, next it travels down through the main windpipe called trachea. From the trachea, air travels into the right and left lungs through tubes called bronchial tubes. From the bronchial tubes, the air travels to its endpoint, the air sacs, called alveoli. As you try to visualize what this looks like, the next time you're at the grocery store, look at a cluster of grapes. The grape stems represent the bronchial tubes, and the grapes are the alveoli. There are thousands of bronchial tube branches that end with alveoli. Let's take a closer look inside the alveoli. The main job of the lungs is to bring air enriched with oxygen into the body, and this happens when we inhale or breathe in. Inside the alveoli, oxygen, shown here as O2, enters tiny blood vessels called capillaries. From the capillaries, oxygen flows to the heart, where the heart pumps the oxygen to all our important organs and body parts. Another job of the lungs is to remove carbon dioxide out of the body. Carbon dioxide, shown here as CO2, is leftover material in the blood from metabolism and needs to be removed. The lungs remove carbon dioxide from the body when we exhale or breathe out. Here are the muscles we use for breathing. Sometimes FSHD can make our breathing muscles weak. Weak breathing muscles can impair how the oxygen comes into the lungs and how carbon dioxide goes out. When breathing muscles become weak, it can make us feel breathless or winded with daily activity, like walking, dressing and bathing ourselves, or when we lay down to sleep. Weak breathing muscles can affect our ability to cough stuff up. I will cover this shortly. While some of these breathing muscles can be weakened by FSHD, our most important breathing muscle is the diaphragm. Next, I will describe how the diaphragm works. The diaphragm separates the chest area from the abdominal area. When we breathe in, the diaphragm moves down and the lungs expand, bringing oxygen into the lungs. When we breathe out, the diaphragm moves up and the lungs exhale the carbon dioxide. We know FSHD is a disease that makes our muscles weak. The diaphragm and other breathing muscles not only help us breathe, but they are important in helping us cough stuff up, like mucus, or if we inhale food or drink and it goes down the windpipe. We cough as a reflex to get that stuff out of the windpipe so it won't go into the lungs. It can be frustrating when we can't cough strong enough to get mucus and stuff up, and we cough so much it can be exhausting. In some cases, weak breathing muscles can affect how the lungs take in oxygen and remove carbon dioxide when we lay down to sleep. If you notice that you are having trouble breathing or coughing, let the doctor know. He or she then will ask you questions specifically about your breathing, like when does it happen and how often do you notice it? Is this new or has it worsened since your last visit? Does it affect your activity and your sleep? Do you have asthma or any other chronic lung diseases like COPD? Do you smoke tobacco or any other products? The doctor might consider ordering a breathing test called spirometry to check your lung function. The doctor might talk to you about a sleep study if you seem to be sleepy throughout the day, have frequent morning headaches, or if you do not feel refreshed after a night's sleep. The American Academy of Neurology provide guidelines for evaluating, diagnosing, and managing FSHD. According to the guidelines, mild respiratory abnormalities are possible. Since FSHD can possibly affect breathing muscles, the guidelines recommend a baseline breathing test called a pulmonary function test on all patients diagnosed with FSHD. If the baseline breathing test is abnormal, your doctor will likely have you repeat the breathing test periodically. A breathing test might also be necessary if you are in a wheelchair most of the time, have a back problem called kyphoscoliosis, or if you have other types of muscle weakness due to FSHD. Lung disease like asthma and COPD are becoming more common and are not caused by FSHD. However, these lung diseases can cause significant breathing trouble, and if you have asthma or COPD, your doctor may want you to complete a breathing test to evaluate these conditions further. There are a variety of pulmonary function tests the doctor can recommend. Spirometry is a common pulmonary function breathing test you can complete during an office visit. This test tells the doctor how well your breathing muscles and lungs work together. The reason spirometry is important is because the breathing muscles can become affected by FSHD slowly over the course of many years. Even though you may not feel breathless with activity, if the breathing muscles begin to get weak, the spirometry test detects changes in lung function early, before you begin to feel breathless. Let's go over the basics of a spirometry test. A spirometry test is commonly known as a breathing test. Kids will call it the blow test because it's like blowing out birthday candles. This test measures how much air you can blow out as fast as you can after you take in a big deep breath. Because it takes muscle strength to inhale deeply and then blow all the air out fast, the more air you can blow out fast, the stronger your breathing muscles are. This test also helps the doctor know how strong your breathing muscles are to help you to cough stuff up. Your doctor, respiratory therapist, nurse, or another trained technician will teach you how to do the breathing test. Sometimes they will have you practice a few times to get it right. Most people can blow through a mouthpiece. You might need to wear nose clips so the air won't come out of your nose when you blow out. If you have trouble sealing your lips around a mouthpiece like I do, the technician might have a special mouthpiece or have you blow through a mask. It is very important for the air not to leak out when you blow fast. You will be sitting down, and then the technician will tell you to inhale a big, deep breath. Then, when your lungs are full of air, to blow the air out fast until you are empty. It only takes about 6 seconds and it doesn't hurt. Most adults and children 7 or older can do spirometry. Occasionally, the doctor may want you to lay on your back to do the breathing test. This gives the doctor an assessment of how strong your diaphragm muscle is and if it is working properly while you are laying down, like during sleep. After you complete the spirometry test, the doctor will ask the technician how well you performed the test to be sure the results are accurate. Then the doctor will look at the results and review them with you. Everyone has their own normal based on age, height, gender, and weight. The doctor will look at the amount of air you were able to blow out and determine if it's normal. The most common spirometry abnormality in FSHD is a below normal lung volume called a restrictive abnormality. You can see on the diagram above, the restrictive volume of air is lower than the normal volume of air. This is caused by breathing muscle weakness and inability to inhale and exhale the normal amount of air. It's like someone giving you a big hug, making it hard to breathe in or out. If your spirometry is abnormal, your doctor will decide what the next step should be. Okay, are you still with me? We've covered a lot of information up to this point. Here, I want to remind you that respiratory abnormalities in FSHD are mild and not common. When FSHD breathing muscle weakness occurs, it can make you feel tired and sluggish in the same way when we overdo it physically with arms and legs. Perhaps you get breathless laying down, or maybe wake up frequently while you sleep, or continue to feel sleepy throughout the day and take a lot of naps. Maybe you start to notice headaches daily, and most days just seem to feel yucky. FSHD can affect sleep quality. When FSHD causes breathing muscle weakness, it can also affect breathing during sleep and how oxygen and carbon dioxide move in and out of the body. If the spirometry test results were below normal, the doctor might recommend further evaluation. This can include a blood test that measures the amount of oxygen and carbon dioxide in the blood. The doctor can also recommend a sleep study to evaluate how well your lungs take in oxygen and remove carbon dioxide while you sleep. Next, I would like to speak about cough. Cough is an important protective response to clear stuff out of our respiratory tract and lungs. That stuff is not supposed to be there, and if it stays, it might cause problems like respiratory infection or pneumonia. We need to cough that stuff up. I would like to explain how FSHD can affect cough. Here are some of the common things that make us cough. That stuff I was talking about. I would like to focus on food, drink, and saliva. These seem to be the most common items that cause frequent cough in FSHD. We can all remember a time when swallowing, something went down the wrong pipe and we coughed until we had tears in our eyes. Food and drink belong in the stomach, but when they get caught in the area of the throat between our trachea, the windpipe, and esophagus, the food pipe, cough comes to the rescue to clear this stuff out so it doesn't get into the lungs. This can happen with saliva too. Saliva may seem gross, but it has many important jobs. Saliva is constantly produced to keep the mouth and throat moist like a lubricant and help break down food before we swallow. Day and night, saliva accumulates in the mouth. During the day, we swallow saliva frequently, many times during the day, and may not realize it. At night, it can end up on our pillow as drool. FSHD can cause weakness in the mouth and throat muscles, making it difficult to swallow. Food and drink can accidentally go down the wrong pipe, and we cough. We use many of our breathing muscles and stomach muscles to cough. Since FSHD can affect our breathing and stomach muscles, it may be difficult to cough the stuff up. When FSHD makes swallowing difficult, even saliva can make us cough if it leaks past the mouth and gets into the airway. Next, I will tell you about recommended ways to manage cough. Approaches recommended to improve cough strength are intended to increase the amount of air you inhale, so when you cough, the larger air volume clears the stuff out. It is very important to discuss these strategies with your doctor first. A respiratory therapist or other trained healthcare professional will teach you the correct way to use these techniques. These strategies include huff coughing, breath stacking with and without a bag valve mask device, and mechanical cough assist device. These techniques need to be demonstrated face-to-face or by video. Research these techniques online to learn more. Then have a discussion with your doctor about including one or more of these techniques in your plan of care. According to the FSHD guidelines, research has determined that some patients with FSHD develop respiratory muscle weakness that can result in respiratory failure and need mechanical ventilator assistance. Although this complication is uncommon, it can happen mainly during sleep. Basically, this means breathing muscle weakness causes shallow breathing during sleep, which results in lower levels of oxygen and higher levels of carbon dioxide in the blood. Shallow breathing during sleep alters the oxygen-carbon dioxide balance I spoke about earlier. This can cause problems over time if not treated. BiPAP is a form of mechanical ventilation that helps to keep the oxygen and carbon dioxide in balance. Let's go over the basics. As a respiratory therapist, if you were my patient and needed to have BiPAP, this is how I would explain why you need it and how it works. Here is an illustration of normal breathing and shallow breathing. You can see on the left, the white dotted lines show how the lungs are fully inflated with air, allowing for normal levels of oxygen and carbon dioxide to be distributed into the blood. Now compare this to the lungs on the right. Here only the top portion of the lungs are inflated, leaving the bottom parts of the lungs without air. This reduces the amount of oxygen and increases the amount of carbon dioxide in the blood. This is how BiPAP works. You are a shallow breather when you sleep. BiPAP is a type of breathing machine that helps you take a normal breath while you sleep. A tube is connected to the BiPAP machine and a face mask. You use the BiPAP machine and wear the face mask while you sleep. This includes naps too. The BiPAP machine is set to deliver a pressurized breath of air through the mask to help you take a deeper breath while you sleep. This inflates the lower parts of your lungs and keeps the normal levels of oxygen and carbon dioxide in balance. It takes time and patience to get comfortable wearing the mask and breathing the BiPAP air, but if you give it time and stick with it, you will notice more energy to do your daily activity. If you are having trouble with how it makes you feel, contact your doctor. If you have problems with the equipment, contact your equipment provider. I would like to finish with a few tips on how to keep your lungs healthy. Tip number 1. Tobacco and vaping products continue to exist and significantly impact lung health. Primary use and secondary exposure to tobacco smoke is known to cause lung disease, like COPD and lung cancer. While data about vaping is still being collected, there is strong evidence that vaping products alter lung function and contribute to lung disease. Vaping is not a safe alternative to tobacco, and the combination of tobacco use and vaping doubles the risk for lung disease. If you don't smoke or vape, stay away from these products. Most people who smoke or vape really want to stop. If you are interested in quitting, ask your healthcare provider about information on quitting programs and quitting strategies. Tip number 2. Eliminate or reduce your exposure to inhaled irritants, like chemical fumes from household cleaners, air pollution during summertime no-zone action days, mold and other irritants known to cause lung problems during lingering exposures. Visit the Environmental Protection Agency website at www.epa.gov for easy-to-read information and practical solutions about how to address indoor air quality problems. Tip number 3. If you have asthma or COPD, as a patient educator for individuals with asthma or COPD, I need to encourage you to continue all medications as prescribed, mainly any daily inhaled medications. Even though you might not feel the effects of asthma or COPD on your breathing, and you are doing well, keep taking these medications because they optimize your lung function and reduce your risk for sudden breathing attacks that may require emergent care. I would be happy to provide a webinar about asthma and COPD in the future if there is interest. Tip number 4. Keep up to date with flu and pneumonia vaccines and discuss the COVID vaccine with your doctor if you are unsure if you should take it. I am happy and relieved to know I am fully COVID vaccinated. Flu and pneumonia are respiratory infections, and research has shown that vaccination is helpful in reducing our risk for flu and pneumonia. I hope you found this presentation understandable and helpful when there is a need to discuss FSHD respiratory matters with your healthcare team. It has been my pleasure and an honor to provide this education to you through the FSHD Society. Once again, thank you.